Hello, my name is Mark Nordenberg. I'm the former chancellor of the University of Pittsburgh and currently serve as both chair of its Institute of Politics and director of its Dick Thornburg Forum for Law and Public Policy. It is my pleasure to welcome you to today's program on behalf of those two groups which are jointly presenting this program. It is our good fortune to be hosting Dr. Arthur S. Levine for a discussion of the battle against COVID-19 and the power of science. Dr. Levine is about to conclude an extraordinary 21-year tenure of absolutely superb leadership as Senior Vice Chancellor for the Health Sciences and John and Gertrude Petersen, Dean of the School of Medicine here at the University of Pittsburgh. Dr. Levine is a physician scientist trained in oncology, pediatrics, hematology, and biochemical genetics. He launched his career as an officer in the U.S. Public Health Service, working as a molecular biologist for the National Cancer Institute, which is part of the National Institutes of Health, also known as the NIH. He stayed at the NIH for more than 3 decades and served as scientific director of the National Institute of Child Health and Human Development for 16 years, from 1982 until 1998. Then someone with an exquisite taste for talent and the last name of Nordenberg persuaded him to leave Washington and to accept a senior leadership position at the University of Pittsburgh. While here, Dr. Levine built an amazing record of achievement, leading Pitt into the top 5 of all American universities in terms of the NIH grants competitively awarded to members of its faculty, which is the gold standard among major American universities. Among the many departments, institutes, and centers launched by Dr. Levine, 2 are of particular relevance to our discussion today: our Center for Vaccine Development and our Drug Discovery Institute. Art also played a critical role in charting the scientific path for UPMC, the legally distinct but closely related University of Pittsburgh Medical Center. UPMC today is the country's largest academic medical center with more than 80,000 employees and annual revenues in excess of $20 billion. To this point, then, Dr. Levine has built a remarkable career, 3 decades of scientific impact at the NIH, a career in the public health service that saw him rise to the rank of Rear Admiral Upper, and more than 2 decades of extraordinary accomplishment at Pitt. And he is not done. When he soon sheds his current responsibilities, he will serve as executive director of the University of Pittsburgh Brain Institute, and he will lead a research lab within the institute, searching for ways to prevent and cure Alzheimer's disease. Art, with that big buildup, you might expect me to start with something that's pretty complicated, but I'd rather start with something basic. There are many, many branches of science. Most of us have taken courses in biology and chemistry and physics, and you have oversight over schools of medical science, dental science, pharmaceutical science, rehabilitation science, nursing, and public health. And while there are differences between them, the bond that seems to tie them all together is a commitment to the scientific method. Could you just describe that for us as a starting point today?
Thank you, Mark, and thank you for inviting me. The scientific method ties together all of the sciences, and it comprises, first of all, a scientist making an observation, commonly in nature, and then formulating a hypothesis, an idea as to what might explain the observation, then doing an experiment, either a laboratory experiment or a clinical trial, and we'll talk a little bit more about clinical trials in just a moment, and finally, having a result, reaching a conclusion. That conclusion is often articulated publicly or published in a peer-reviewed journal, and eventually becomes part of the body of fact and evidence that drives the further evolution of science. A good example might be a person, a scientist, recognizing that a mouse has a tumor and hypothesizing that a particular gene might be the cause of that tumor, whereupon the scientist would use genetic engineering to insert the gene that he proposes to be a cancer-causing gene into the mouse, doing a control, for example, the gene that causes blue eyes rather than cancer, having a result. Indeed, he picked the right gene, publishes it, and wins the Nobel Prize.
Well, that would be a happy ending, wouldn't it? When I think about the scientific method, one of the ways I might describe it is a deep commitment to and the rigorous pursuit of truth or factual accuracy. And we live in a time when the truth too often seems to be a casualty. And when we have heard the birth of new terms like alternative facts, why is factual accuracy so important in science?
I would go beyond science, Mark, and say that seeking the truth, seeking fact and evidence is critical to how we live our lives as individuals and how we comprise a healthy and productive society. And failing to, in fact, have our lives led by fact and evidence, we can cause great harm. For example, in medicine, if we do not develop therapies and prevention based on fact and evidence, we can not only squander money, but we can also cause death. And so it's without question important that as humans and as members of a society, we have to let ourselves be guided by science and fact.
So to go back to a term you just mentioned a few moments ago, clinical trials, when it comes to treatments for or protections from disease, how is it that we go about establishing the truth?
Well, the truth starts, in fact, at quite a basic level. We're curious about a disease in a fruit fly, or a worm, or a mouse, or a monkey. And so our curiosity leads us to gain insight into that disease that we have perceived. And that's followed by our hypothesizing a given treatment for that illness or disease. And following the scientific method, vetted that treatment, we're then ready to try it in human beings. And so we undertake clinical trials during which we randomly administer that treatment, a drug or even a device, and have, because it's a random assortment, other patients who in fact have a placebo, something that we know won't benefit at all. And occasionally we assess not only a new treatment, but a new treatment against the current state-of-the-art treatment. And then we carry out early trials just to make sure that our proposed treatment is safe. And once we have demonstrated safety, we're ready to try different doses. And once we've achieved the right safe dose and the effective dose, we continue with larger groups of patients until we're sure that we have a treatment that will benefit a lot of people with a given disease safely and effectively. And that comprises a randomized clinical trial. I might mention that currently at Pitt, we've started a new approach to clinical trials called Learning While Doing. And that's been critical in the COVID-19 pandemic because we don't have time to do a conventional clinical trial where we have to identify people, bring them in, stratify them according to their age and their weight and so forth. But now we can give a proposed drug, for example, hydroxychloroquine, and we can do it randomly so that a person may or may not get that drug. Well, all of our data is now recorded in electronic health records, and Dr. Angus, who is the principal scientist involved, has pulled in other countries, and so we have a lot of electronic health records. We can scan them immediately to see how people did on hydroxychloroquine as opposed to a placebo, apply artificial intelligence to the result, and have a clinical trial result with unprecedented acceleration.
Well, that is clearly a rigorous method, now enhanced by the use of technologies as you described it. Even in science, though, there are some times when the truth seems to be a casualty, or factual accuracy seems to be a casualty. What are the principal causes for that?
I think they're both, I think it's all a matter of bias, Mark, and that bias can be conscious or unconscious. We commonly talk about conflict of interest, people presenting untruth as opposed to truth because they think that they will be able to line their own pocket by so doing. But beyond that kind of what I would call greed, people can be motivated by wanting a promotion, wanting to win the Nobel Prize, all kinds of biases. They may not, as I said, even be aware of what is conflicting their ability to recognize the truth. And in fact, this is particularly heated when one is faced with not only a global scourge like cancer or AIDS or Alzheimer's disease. The idea that one will effect a cure of any of these diseases or a vaccine for the pandemic can be so profound that it touches the height of a soul's aspiration and hope and wishing to win the Nobel Prize. And so that bias, even unconscious, can certainly distort how the scientific method is employed.
And today there are frequently expressed concerns that the bias in question might be political pressure that would lead either to the skewing of results or in some cases the suppression of facts. Do you see those concerns within the scientific community today?
I do. I think that, again, because of the extraordinary impact of this pandemic, one that we haven't seen for 100 years, because of that momentum, I think that the political process has risen even more to the fore than might have been the case historically. And I would say that science, now we can call it the truth, can be influenced not only by politics, it can be influenced by religious belief, any set of preconditions, when in fact, one either denies the truth or misjudges the truth or misinterprets it, primarily because it's difficult for our brains to keep competing ideas together at the same time. We are often a binary people. We want things to be all one way or all the other, but science is much more commonly in the middle. And so it really suffers when anything forces it to be all one thing or all the other.
And in fact, all of us have had experience, I think, with this in the middle nature. And so let me ask you, either as a practicing physician or as a professional who has the ability to impact public policy, I assume that you would not only have to be driven by the best available evidence, but would also have to acknowledge the limitations of that evidence as a part of your presentation.
Absolutely. And in two ways, I think good scientists approach this kind of evidence. We present the evidence in, for example, in talking with a patient, in language that is simple, intelligible, both intellectually and emotionally, not only correct, but compelling. But at the same time, we allow for the limitation of our knowledge to that date, because science continuously evolves. The fact today may yield the next day to a new experiment and a new result, which in fact tweaks that little bit of truth. But it's very important that we, in fact, inform, in this case, a patient of side effects, of risks, of the limitation of our knowledge, our hope that our treatment will be successful, but we have to walk a fine line between hope and guarantee. I think that probably addresses the question as you put it.
It does. And what I'd like to do is just take it one step further by going back to the now well-known, well-publicized example to which you referred a moment ago. And that is the recommendation by a visible public figure that people consider using hydroxychloroquine as a form of protection against the COVID-19 disease. Now, this has gotten so much attention that I assume you must have some sense of the existing state of scientific knowledge with respect to that use of that drug.
Right.
Would you recommend it to a patient?
No, I would not recommend it to a patient, especially now, because we finally have clinical evidence that the drug not only is ineffective for this purpose, but it is potentially harmful. The World Health Organization had launched a clinical trial of hydroxychloroquine. They had a surprising number of deaths due to cardiac arrhythmias and terminated the trial somewhat prematurely because they didn't want to cause any more heart disease. But the fact of the matter is that there was no evidence to begin with, other than that hydroxychloroquine is a very good and useful drug in the treatment of autoimmune diseases like lupus and rheumatoid arthritis. It's a very good drug for the prevention of malaria, but there was absolutely no evidence at any time other than anecdotal evidence that it might be effective. But science doesn't depend upon anecdote. It depends upon, as I've described it, the use of the scientific method. So as a matter of public policy, it was, in fact, a bona fide danger, as we've now seen. We knew that cardiac arrhythmias could result from this drug. That was the one evidence that we did have, but we had no evidence of its efficacy.
And again, to go back to the description you provided a moment ago, that recommendation most often was followed by the question, what do you have to lose? But as a physician or as a public health professional, you can't leave that question to the patient or the community, can you? You've got to explain what you have to lose.
That's correct, because in this case, as I've already said, the patient could have lost his or her life as a consequence of the side effects of the drug. At the same time, the patients who benefit from that drug, whose health depends upon that drug, I mentioned lupus and rheumatoid arthritis, suddenly had no access to the drug or limited access because it was all being ordered by the people who thought it would be a preventative. But that also leads me to the notion of public policy, because in fact, celebrities and leaders have a powerful message to give to the rest of us. We respect them for their achievement, for their leadership, for their stature, for the asymmetry between them and us. But the fact of the matter is that they dare not abuse that privilege by influencing public policy based on untruth rather than truth.
And of course, we're all familiar with this. You've got to explain the possible risks because we've all had conversations with physicians about side effects. We've gone to the pharmacy and had the pharmacist want to talk to us about side effects. You open up the medication and you get a disclosure form likely written by lawyers and not by doctors about the side effects. So that really is an ingrained part of our system. And when I think about what you said about the lupus patients, it reminds me in some way about masks. You know, we're told to wear masks mainly to help others, to advance the public health. And similarly, in this case, it may have been a motivation not to go out and purchase this particular drug for COVID-19, knowing that the supply needed by people with lupus, arthritis, as you said, malaria prevention, the supply available to those people was going to be diminished. There is a long history in our country, and I tend to, federal investments, big investments in science. And whether I'm right or not, in the course of my life, I think that began to happen when the Soviets launched Sputnik and the great space race was launched. So there are a lot of federal agencies that support scientific research that is not related to health. But the three agencies we have heard a lot about over the course of the past few months have been the National Institutes of Health, or NIH, the Centers for Disease Control and Prevention, or CDC, and the Federal Drug Administration, or FDA. Can you tell us a little bit about those agencies and their missions?
I will, Mark, but before I do that, I did want to follow on your earlier comment about masks, because this is an issue that is very important to me, to all of us, because it touches on the issue of individual rights versus the rights of a society. And we've seen this over and over again. Henrik Ibsen wrote about it. But the fact of the matter is that when I look at the picture of the people swimming in the Lake of the Ozarks and ignoring the contagiousness and the perniciousness of this horrible virus, it points out once again how critical it is that we effect a fine balance between the rights of an individual and the larger rights of society. Now on to your question. The very first presidential science advisor was Vannevar Bush, and he was the advisor to FDR. And he was a remarkable human being. He was a trained engineer. He'd been president of the Carnegie Institution in Washington, and before that at MIT. His notion was that federal patronage of science was an absolute must. In wartime, he had been one of the fathers of the Manhattan Project, but in peacetime, he thought it was very critical that the federal government in peacetime support science. And it was the momentum that he gave, then fostered by FDR and thereafter, that accelerated the development of the NIH, the FDA, and the CDC. The NIH is the National Institutes of Health. Health is part of its name because ultimately that's our goal. But I would point out that Bush also was fixed on two notions. One was the importance of basic science. Before one couldn't translate science. You know, we use translational research now as a cliche, but the fact is we can't translate something that hasn't been discovered. And so the notion that you would first have to start with yeast or plants or flies, and just out of curiosity, without knowing where it was going to go, discover something that years later might be applicable to the human condition, motivated Vannevar Bush. And secondly, he was motivated by internationalism and the idea that no country had primacy for invention and discovery. The examples were then legion. They continue to be legion as to how much scientists are alike country to country, and therefore how much we have to respect how science is dealt with as an international entity. Back to the three entities. The NIH has an intramural program. It has a campus in Bethesda, Maryland, that uses about 10% of the federal appropriation. About 90% is shipped out from Bethesda to institutions all over the country and a few worldwide in the form of grants and contracts. As you mentioned, we've been fortunate at Pitt to have to now be amongst the top 5 such institutions nationally. The intramural program is a unique entity. There are very few like it anywhere in the world because it's not grant or contract dependent. The full-time scientists in Bethesda are able to take risks. They're able to pivot on a dime because they don't have to submit a grant and have it reviewed and a year later find out whether they got it or not. And so whether it was AIDS or Ebola or now COVID-19, many scientists in Bethesda have turned their full attention. They've changed what they do in the lab to attack these huge assaults. The extramural program is different. It does work by grant and contract. It works by peer review. It's a more determinative and studied, highly disciplined program, but the two programs accomplish two different things. The CDC is based on communicable diseases, toxins, injuries, things that can hurt us, but that are communicable, that can go from one person to another, or that can taint or pollute an entire group of people. It too has an intramural and an extramural program. The intramural part of the CDC is the Epidemic Intelligence Service, a first-rate entity. The Public Health Service, by the way, is the major workforce for all of these federal health-related entities. The FDA, the Food and Drug Administration, is responsible for ensuring the safety of our food, the safety and efficacy of the drugs that we use, whether they're prescription or over-the-counter. And it too has an important intramural program. It has its own laboratories, also in the Washington area. And the three entities together are the ones that serve the health of individuals and the health of our society as a whole. And they are all informed by science elsewhere in the world, and in turn, they inform that global science.
There have been concerns expressed that the agencies, and particularly the CDC, have had their roles minimized to the disadvantage of American health and world health. Is there anything you could say about that?
Well, I will. And once again, there's no place in science and in human health for politics. And of course, the issue here is that once you introduce any system of belief or aspiration other than the one that speaks the truth, you're going to bias the result, and that will in fact be exceptionally dangerous. So these federal entities currently, I believe, have all been politicized. I had thought that the NIH was exempt. The NIH, of course, having built my career there, I speak of it as the gem of the government's crown. But the NIH has had always bipartisan support. It's had Republican support because the Republican Party knows that research is great for the economy. It's had Democratic support because it's been great for humanism. But whatever your belief, it has gelled around the idea of biomedical and behavioral research. Once again, I thought that it was exempt. It's not exempt because the administration has seen fit to now cancel a big grant that in part supported the Wuhan Institute of Virology in China. Now, the fact of the matter is that that particular institution is absolutely top tier, and it is critical that it survive because bats have hundreds, if not thousands, of coronaviruses, and they have to be isolated and studied and understood so that we don't have another pandemic. So we don't want to shed the Wuhan Institute, nor do we want to limit the support that we and other countries give to that institute and institutes like it. We don't want to diminish science because of belief or a goal that has nothing to do with the truth. So I'm sure you're aware that some 77 Nobelists have now written to the administration and publicly protesting the end of that grant purely for political reasons. The FDA and the CDC have always been subject, particularly the FDA, to political pressure because of lobbying by the pharmaceutical industry. And that has now been accentuated. The CDC has been less affected politically, but if you're talking about things that can hurt people, particularly toxins, then once again, industry has a heavy political role. However, the scientists working for these three entities are driven not by any of those goals. They're driven by their curiosity, their intellect, their zeal, the fire in their belly, their creativity, and so forth. And they shy away from anything, hopefully, that could taint that truth.
Well, and there has been the view expressed that whether you're dealing with the threats to the World Health Organization and its funding, We're talking about the failure of the United States to join forces with our European allies in the search for a vaccine, or the cancellation of this grant because some part of it involved the institute at Wuhan, that we really are inflicting a form of punishment that ultimately will be felt in terms of the health of Americans and the health of others around the world.
Right.
Now, I want to do two things with this. The first is in doing my research, I saw that you joined the NIH in the mid-1960s, and you became the scientific director of your agency in 1982. That Dr. Fauci joined the NIH in the mid-1960s and became the director of his agency in 1984. Assuming that you know him, are there any things you would like to say about the responsibilities that he has been asked to shoulder and how he's bearing up under the weight of them?
Well, Tony is an exemplar. He's a model physician scientist. In fact, he's a very gifted fundamental scientist, an elected member of the National Academy of Sciences, and an excellent and committed clinician. Tony and I, to some extent, grew up together because we both came as young men to the NIH. Tony has had an exceedingly long and highly productive career in the federal government, not for salary, certainly, but because of his commitment to the human condition. I think that he has had a critical role to play now, a heroic role given the context in which he's had to operate. It's produced a great good, in addition to the fact that his face is now portrayed on bagels and donuts in New York.
And in Pittsburgh occasionally, I understand.
Right.
But let me ask you more generally, Art, is this problem of the hollowing out of talent within the national scientific enterprise, is that a problem today?
It is. I think that, once again, it's less of a problem at the NIH because of its strong bipartisan support throughout history. It's a major problem at the Environmental Protection Agency for obvious reasons. That agency has a wonderful cohort of scientists who understand geology, climate, oceanography, and so forth. Again, all part of the nature in which we find ourselves. And so there, I think we're seeing a real hollowing out of talent. Climate control is a matter of intense political view, potentially tremendous political distortion because it's so engaged with industry and with money, with circumstances that have nothing to do with the scientific understanding of what our climate is about. Less hollowing out in the other entities, although if matters continue as they are, or in fact accelerate, I certainly would predict more hollowing out.
When you came to the University of Pittsburgh, you were moving from one wonderful institution to another. This was an institution that already had made significant contributions to human health. The most directly relevant example being the development by the Pitt team led by Jonas Salk of the vaccine that won America's war against polio 65 years ago. With that as background, are there things that you can say about the nature of COVID-19 and the likelihood of a vaccine being developed within the foreseeable future?
Yes. I think that COVID-19 is a vascular disease, Mark. I think that this is not only a highly contagious virus, but a very pernicious virus. With regard to contagion, if in fact one infected person could infect 3 others, and we're not too far from that, and the 3 would infect another 3 and would have 9, and then 27, and then 81. If 60 days went by and the incubation period is 5 days, there'd be 12 such incubation periods. And at the end of the 60 days, the first infected person would have given rise to 986,914 infected people. And in fact, that's what we've seen. We've seen about that number of people in the 90 days that we've been following this pandemic. Pernicious because that virus is in the lining of every one of our blood vessels. And that explains why we have symptoms and signs from the brain to the toes. It's also a very pernicious disease because its prime target is age dependent. The older one gets, the less strong our immune response is. But in this particular case, it's a little bizarre because we have too much immunity to the virus, almost an autoimmune-like entity, or we have too little. So we have this combination of crowd behavior, contagion, perniciousness, age dependence, which makes this pandemic, I think, particularly frightful.
Well, and as we talk today, there are something like 5.6 million cases around the world, 1.7 million in this country, more than 350,000 deaths around the world, more than 100,000 in this country. And so it sometimes seems as if everyone everywhere is hoping for a vaccine.
Right.
But that's not quite true, is it? There are those who are opposed.
There are, I would call that guilt by association. And the classic example is the belief by some, including many celebrities, who, as I said, often have a message that many listen to. But guilt by association, for example, in the case of infants and small children who develop autism, having been vaccinated a couple of weeks before, or whose autism emerges at that point. But we're talking about millions and millions of infants and children who have been vaccinated. And so simply through random bad chance, a small cohort of children will have autism, but not related by cause and effect to the vaccine. However, because of that association in time, the anti-vaccine movement will seize upon it, much to the detriment of others. We have a good example of what happened when children that hadn't been immunized against measles went to Disneyland and caused a mini epidemic of measles there.
Well, Dr. Levine, you have devoted your life to science. Most of the rest of us have led better lives because of science. I could talk to you for much longer, as I have done on many occasions, but our time is short today. So I want to conclude first by thanking you for joining me. And when I say that, I mean in particular, first for joining me more than 21 years ago and coming to the University of Pittsburgh, where you have made such a difference. And you have been both a wonderful partner and a wonderful friend. And of course, I also am grateful to you for joining us today. I'm grateful for your many distinctive contributions and the impact they've had here at Pitt and on the broader world. And I look forward to further interaction as you launch the next chapter of this extraordinary career as the executive director of the University of Pittsburgh Brain Institute and as a committed Alzheimer's researcher back in your own lab. Thank you very much.
And thank you, my friend.